Good morning, everyone. Estou muito feliz de estar aqui hoje com vocês, introduzindo mais uma reunião geral do Departamento de Psiquiatria da Faculdade de Medicina da Universidade de São Paulo. Hoje, mais uma vez, contamos com a presença ilustre de mais uma convidada internacional, Jennifer Dwyer. Ela é uma pesquisadora e professora de Yale, do Childhood Student Center, e que vai ser, com certeza, uma grande reunião. Eu vou apresentar primeiro em português e depois eu vou fazer uma breve apresentação em inglês, porque iremos seguir em inglês essa reunião geral. O título da reunião é Ketamine as a Treatment for Depression and Suicidality, a Lifespan Perspective. Quem vai apresentar é Jennifer Dwyer. Ela recebeu seu título de médica e seu título de doutor em farmacologia pela Universidade da Califórnia, Irvine. Completou sua residência e treinamento na Universidade de Yale, sendo atualmente uma psiquiatra de adultos e da infância e adolescência. Ela é professora assistente em Yale, no Untitled Chapter Center, e no Departamento de Radiologia e Imagens Biomédicas, da Yale University, onde co-dirige o programa de depressão pediátrica de Yale e lidera uma equipe de pesquisa que estuda a eficácia de novas intervenções para a depressão pediátrica e avalia o circuito neural de resposta terapêutica de ações. Para comentar, temos a honra de contar aqui com o nosso ex-residente, também pesquisador sobre ketamina, o Vitor Cavenaghi. Ele é médico formado pela Faculdade de Medicina, Faculdade de Ciências Médicas da Santa Casa de São Paulo, residência em psiquiatria pelo HCFM-USP e assistente do pronto-socorro do Hospital das Clínicas da Faculdade de Medicina da Universidade de São Paulo. Atualmente também fazendo pesquisa em ketamina com o Gerald Sanacora da Yale University. E para comentar, talvez um dos maiores especialistas brasileiros no tema, talvez não, com certeza, o professor Acioly L. Ele é professor adjunto, livre docente do Departamento de Psiquiatria da Escola Paulista de Medicina. E é coordenador do PRODAF, Programa de Transtornos Afetivos da Unifesp, e coordenador da Clínica de Cetamina da Unifesp. So, now moving for English language for everyone. I'm so glad to have Jennifer Dwyer here. I asked to Vitor, Professor Orestes and Acioly, just to mute their microphone. And Jennifer, we are so glad to have you here. I'm sure you have a great presentation, and you're gonna have an hour of your presentation. Then Professor Vitor and Professor Acioly will give their comments. So please, you can share a slide and start your presentation.
Okay, excellent. Thank you so much for inviting me and for the wonderful introduction. Let me share my slides. Okie dokie. Are you all able to see?
Yes. If you'd like to put the entire screen, this just.
Oh, let's see. Are you not able to see the whole screen? Let's see.
No.
Oh, let's see. Let me try one more time. Your entire screen, allow. Okay. Okay, and now if I go here, okay, success?
Perfect.
Okay, wonderful. All right, well, thank you again for the invite. I'm really excited to talk about this topic. It's a topic that's close to my heart, and I'm excited for the discussion that we'll have at the end of the talk. So I'm talking about ketamine as a treatment for depression and suicidality, a lifespan perspective. In terms of disclosures, I have no relevant conflicts of interest to disclose. I've listed my research support here, which is mostly from foundation funding, and then a grant from the NIMH. So here's what I wanted to cover today. I'm going to start by talking a little bit about depression and suicide across the lifespan. Then I'm going to talk about interventional psychiatry treatment modalities for depression in adults. And I'm going to focus mostly on ketamine and S-ketamine, but I have a little section at the beginning just talking about, what does interventional psychiatry encompass? And then I'll spend some time talking about pediatric ketamine. So this is the work that my lab has been doing, and I'll talk about a single dose randomized controlled trial in adolescent treatment-resistant depression. And then I'm going to spend the last portions really focusing on what I identify as the key gaps in our understanding, and then some of the ways that our lab is working to address those gaps. And hopefully that's a good jumping off point for discussion. So major depressive disorder is a common psychiatric disorder. It's associated with considerable suffering, morbidity, mortality, and cost. The lifetime prevalence of adult MDD in the US is estimated to be 17% overall, but that's higher in women than in men. The 12-month prevalence is approximately 7%. In the year 2000, which feels like a long time ago now, the economic cost was nearly $83 billion in the US, and that went up to $210 billion by 2010. And by 2030, the World Health Organization projected that worldwide MDD will be the leading cause of disease burden. I think you all are familiar with MDD diagnosis in adults. So according to DSM-5, you need to have 5 or more symptoms that are represented here in the schematic that are present during the same 2-week period, and that they're present in a way that impacts functioning. And you can't just have 5 out of 9. You also have to make sure one of those 5 is one of these 2 at the top that has the red dot. So either depressed mood or anhedonia, so a loss of interest or pleasure in things that you previously enjoyed. And like most DSM criteria, excluding symptoms that are clearly attributable to another medical condition. So what is the treatment space for adult MDD? Most treatments are a combination of medications and psychotherapy. I'm going to focus on the pharmacologic side. So most of our current medications are based on serotonergic and to a lesser extent noradrenergic mechanisms. So we have a lot of different individual medications, but not a lot of distinct mechanisms or distinct neurochemical systems. In the classic STAR-D trial, 1 in 3 depressed patients experienced a remission with their first antidepressant trial. So 2/3 had to go on to something new. And then only 2 out of 3 cumulatively experienced a remission after 4. And I just put an exclamation point because that's a lot of treatments to go through, 4 sequential treatments. And it's really important that we treat people effectively because MDD is associated with severe impairment in a large amount of adult cases. So this is data from SAMHSA in 2017 with US adults showing that 64% that met criteria for MDD identified as having severe impairment. So it's important that we get treatments that work out to people in an efficient way. I'm going to switch now to talking a little bit about adolescence, and I thought it would be good to have a slide just to define what adolescence is to me, or how we're sort of operationally defining adolescence. So it's a period of transition from childhood to adulthood, so conservatively estimated to be 12 to 18 years in humans. And there's a unique set of behaviors that are conserved across mammalian species. So things like increased risk-taking, increased novelty-seeking, and spending a lot more time with peers and sort of moving away sometimes from family. But it's also an important clinical time, right? So it's the time of onset for substance abuse and for the emergence of some neuropsychiatric disorders. And I believe that these unique features, both the strengths and the vulnerabilities, are mediated by changes in the structural, functional, and neurochemical organization of the brain during this time period. So from my training, I've really appreciated the idea of a lifespan view of psychiatric illness in general and MDD specifically. So I think many of the clinical folks will have the experience of talking to adults that have depression that report that their symptoms really started during the teenage or the early adult years. And we know that depression that begins in adolescence is associated with a persistence into adulthood. We also know that pediatric depression is associated with more severe clinical outcomes and courses compared to later onset MDD, so almost selecting for this more severe phenotype. And we know that early onset depression is associated with increased risk for poor social and academic functioning, early pregnancy, physical illness, and substance abuse. And so I really believe that treating folks early and trying to get pediatric patients remitted more quickly can really have an impact that lasts the rest of their life. I just make a point about diagnosis here that there are probably more similarities than differences in how you diagnose pediatric MDD. This is a figure we made from a review in JCPP a couple of years ago. And the salient point is here with these cardinal symptoms. So in adults, depressed mood or anhedonia have to be one of the features. And in pediatrics, while anhedonia remains the same, it's not just depressed mood, but irritable mood. And so that actually really expands the entry point for a depression diagnosis considerably. And I think is an important point when people say, my kid is just so cranky, that we should be thinking about whether the other criteria for this disorder are met. And adolescent depression is a significant health problem. So nearly 1 in 5 adolescents may experience a major depressive episode or major depressive disorder by the end of the teenage years. And suicide is now the second leading cause of death in this age group. And depression is thought to increase the risk for suicide nearly 30-fold. So it's really a potent and hopefully modifiable risk factor for suicide. The TADS trial showed us that 40% of adolescents with MDD don't get better after the initial treatment with SSRIs. And then the Tordia trial built on that, looking at this SSRI-resistant population, and found that nearly half remained depressed despite changing medications and adding psychotherapy. And I think what is really a shame is that there have really been no major updates to evidence-based prescribing recommendations for pediatric TRD since the Tordia trial ended, and that was over a decade ago. And so I think clinicians have really been kind of stranded in this non-evidence-based territory. And maybe some of you identify with this experience of having kids that sort of get to the end of the Tordia algorithm, and then the evidence is skinny if it exists at all. I'll talk a bit about pediatric suicide facts. So this data is getting a little bit old, but this was among high schoolers in the US. A survey project where 17 had considered attempting suicide in the last year. 14% reported having a suicide plan in the last year. 8% reported actually attempting suicide in some way, shape, or form in the last year. 3% made a suicide attempt that required medical attention. And then the suicide death rate is 13 per 100,000 in the US, and that comes out to about 5,500 deaths per year. And for me, it helps to sort of anchor those kinds of numbers on something that's more tangible. So this is Hamden High School, which is in Hamden, Connecticut, just down the street from Yale. It's a pretty big high school. It's got 1,100 students. And so this is really the equivalent of losing 5 Hamden high schools a year to suicide, which I think is totally unacceptable. And we have a moral imperative to try to figure out some strategies to reduce those numbers. So basically, to summarize the introductory slides, I think we really need better therapeutic options for treatment-resistant depression and suicidality across the lifespan. And the hope, as a neuroscientist, is that knowing something about the brain and the circuits that underlie mood and affect might help us come up with some better treatments. So now I'm going to shift to the second part of the talk and start talking about interventional psychiatry. And I thought it would be useful just to kind of talk about what interventional psychiatry encompasses. There are some places that have a really robust interventional psychiatry community already, and other folks that are doing some interventional psychiatry technique don't sort of name it as such. So this was a term that was coined back in 2014 by Nolan Williams and Mark George down at MUSC. And I think part of it might have been, thinking about other medical services that were getting interventional specialties. So interventional cardiology or interventional radiology, and kind of wanting to join the club with an interventional subspecialty. But what does it actually encompass? It encompasses some older techniques, some newer techniques, and I'm just going to list here some of the things that have been considered to fall under this title. And they're really techniques that look at neuromodulation, and then also these rapid-acting pharmacotherapies that tend to require either an infusion or a nasal spray. So anything other than PO seems to get lumped into this category. So ECT falls under interventional psychiatry service purviews, and obviously ECT has been around for a long time and can be really a life-saving treatment and is still being refined. RTMS, repetitive transcranial magnetic stimulation, also falls under IPS services. Deep brain stimulation or vagus nerve stimulation would be considered here as well. And then we get into sort of the rapid-acting pharmacotherapies. So S-ketamine or Spravato, which we'll talk about, and ketamine infusion therapy fall under this distinction. And then also brexanolone infusion therapy. So brexanolone was recently FDA approved for postpartum depression. It's a GABAergic modulator that's based on a neuroactive steroid, but is another one of these infusion treatments. So I'm going to focus now on ketamine. That's the title of the talk and what you came for. So that's what we will talk about. This is a cartoon of ketamine in the binding pocket of the NMDA receptor. So as you all know, ketamine's a medication that's traditionally categorized as a dissociative anesthetic, a non-competitive NMDA receptor antagonist. And it's been used in anesthesia, including pediatric anesthesia, for quite some time. And at higher doses, so the doses listed here ranging from 1 to 4.5 milligrams per kilogram, pushed very rapidly, so over a minute. And that contrasts with the doses that have been used in psychiatry, which have generally been much lower and slower, so this 0.5 milligrams per kilogram spread over 40 minutes. Let's talk about ketamine's acute side effects and safety profile. So ketamine transiently increases heart rate and blood pressure. These are dose-dependent effects. It can increase respiratory rate, but it can at higher doses cause respiratory depression. It can cause nausea, dizziness, diplopia. It can cause emergent anxiety or dysphoria, dissociation, sensory distortion, sort of messing with sensory gating functions, and derealization. So why would we tolerate all these side effects? Well, we tolerate them because there was exciting data that came out. This is a very early paper back from 2000 at Yale, the Berman paper, that showed that ketamine rapidly improves depressive symptoms in adults. And so this is showing the time course with placebo in the open circles and ketamine in the filled circles, showing a reduction in depression scores at 1 day, 2 days, 3 days. And that really contrasts with our traditional antidepressants where, the x-axis would extend way past my computer screen, which takes 2, 4, 6, 8 weeks to improve depressive symptoms. This inset is showing the time course for the side effect profile, so the CADs or the dissociative symptoms, and this is just showing that the time course for side effects is distinct from the time course for efficacy. So that was back in 2000, which I can't believe is 21 years ago. Many studies have been done since then. This is a meta-analysis, which is also actually getting sort of dated from 2015, and this is summarizing a series of ketamine studies and showing that there's an odds ratio of about 10, so a large effect, and this is 1 day following initiation of ketamine treatment, and then seeing that that effect decreases as you get further out in time, so reduced somewhat by 1 week after initiation. And then I think some really exciting data that's been discussed more recently is this idea that ketamine may also be anti-suicidal in adults, so even after controlling for its antidepressant effects. This is a figure from my colleague, Sam Wilkinson, who published this meta-analysis in AJP, and this is showing the reduction in suicidal thinking even after controlling for the improvement in depressive symptoms. And then as a child and adolescent psychiatrist, this really hits home to me because we live in the era of the black box warning, right? Which is controversial still, but I think this idea that a medication that's designed to treat your depression, but could paradoxically allow some increase in suicidal thinking is a really scary thing for clinicians and for families. And so to be able to have a compound that's both antidepressant, but then anti-suicidal in its own right would be a big help, I think, in our clinical populations. So I talked about ketamine. I'll talk a little bit about S-ketamine. So S-ketamine is the left enantiomer of the racemic version of ketamine. So Janssen developed this compound. Some of the reasons they chose the S versus the R was that the S has sort of a higher affinity for the NMDA receptor. And there was a thought that there might be less potential for dissociative side effects. So better binding at the presumed therapeutic site and less side effects was sort of why they went for that. And this medication was FDA approved not too long ago. So this is a nasal spray, and it's been approved when given alongside a traditional antidepressant for treatment-resistant depression in adults. This is just a figure from one of the earlier S-ketamine trials that shows that S-ketamine in conjunction with a standard antidepressant rapidly reduces depressive symptoms in adults with MDD who are at imminent suicide risk. So these studies were done in hospitalized inpatients, sort of at the peak of their suicidality. And you can see here an effect that pulls out at 4 hours post-dose and remains significant at 2 days. And then this is looking at the time course. Again, you can see that I think another message from this figure is that the standard of care actually isn't bad. I mean, these are pretty severe patients, and you can see even the placebo group, people tend to get less depressed, or at least report less depressive symptoms in the hospital getting standard of care treatment. But then there's a separation, so an additional benefit from those who are receiving hospital care, a standard antidepressant, and S-ketamine on top of that. So part of the excitement about ketamine was thinking about, wow, we finally have something that's targeting a different mechanism of action. We've had many years of serotonergic or noradrenergic compounds. And so it's exciting that we're targeting something different, and maybe that will help us with that population of folks whose symptoms just don't respond or don't respond fully to what we've got now. I put this cartoon up almost as a joke because I feel like our scientific cartoons have gotten borderline unreasonable. This is a good cartoon because it has a lot of the relevant information, but maybe it's information overload, but I'll direct you to the salient points of it. I think on the right is sort of a healthy synapse. It's got the right amount of glutamate and glutamate receptors. It's got BDNF that's signaling. It's got sort of a nice, plump, happy shape. And then on the left, you see sort of a stressed, depressed kind of synapse that has reduced synaptic glutamate, reduced postsynaptic receptors. You don't see BDNF anywhere on that cartoon. And so the question is, how does ketamine get from a stressed synapse to an improved or a healthy synapse? And one hypothesis is that ketamine is sort of selectively, particularly at the doses we're talking about, is selectively inhibiting NMDA receptors on inhibitory neurons. And so by doing that, it's sort of disinhibiting the whole system and allowing a rapid synaptic burst of glutamate that promotes BDNF release and mTOR signaling, local protein synthesis, increased spine density, and promotion of synaptic plasticity. I have it in plain English here instead of the cartoon. The main idea is that ketamine enhances glutamatergic signaling and promotes synaptic plasticity. The prefrontal cortex and the hippocampus are key sites of action. There's more than one hypothesized mechanism. So I just told you about one, this idea of NMDA antagonism on inhibitory interneurons, really facilitating glutamate signaling. And then a second, but I don't think mutually exclusive hypothesis about ketamine metabolites actually directly activating AMPA receptors. Either way, pro-glutamatergic, pro-synaptic plasticity. If you're interested in this kind of stuff, we have some cool videos through the National Neuroscience Curriculum Initiative that sort of breaks this down with some good cartoons and a 10-minute bite-sized segment. So I encourage you to check that out if you're interested. Okay, so what do we know about ketamine in pediatric pharmacology? And I think an important point that we should acknowledge up front is that there's a lot of active development going on during the adolescent period, particularly in prefrontal cortex and in the very systems that we think ketamine is working on. So there is synaptic pruning of glutamatergic synapses. Animal studies suggest that there's relative changes in GABAergic interneuron profiles, and there's even changes in the receptor subunit compositions of some of these really key receptors. And so I think it's important that just because something works in adults, I don't think it's safe to assume that it works in pediatric patients or even that it works in the same way. We really need to ask these questions and determine the answers empirically. What does encourage us was that, there was some preclinical data suggesting that ketamine reverses depressive phenotypes in adolescent rats. And then from a safety perspective, we know that ketamine has been used safely in pediatric anesthesia for over 50 years. So in ERs all over the country, there are kids getting ketamine for anesthetic reasons in a safe way, or what we think is a safe way. So we asked a question a few years ago, which is sort of a simple question, but is a single dose of ketamine safe and effective in adolescents with treatment-resistant depression? And we sort of shorthanded this as the KIDS study. This was funded by the following sources. And the data from this just came out a few months ago in AJP. So I'll tell you a little bit about who we were studying. So we were looking at adolescents. We were looking for depressed adolescents. We were looking for significantly depressed adolescents, so having a children's depression rating scale score of over 40. And we were looking for treatment resistance, which here we defined as having failed to achieve remission with at least one prior antidepressant trial, so 8 weeks at therapeutic dosing. Although, as I'll show you in a couple of slides, most of our folks had tried and failed multiple medications. And then this was a ketamine in addition to kind of study. So we asked folks to remain stable on their psychiatric medications for the month prior to enrollment, and we allowed them to engage in any ongoing psychotherapy. Who did we not include? So this was an outpatient study. So we excluded folks that were inpatient hospitalized or had a degree of suicidal ideation that required referral for inpatient hospitalization. We excluded people with a history of psychotic disorder or manic episode. We excluded folks with a history of substance dependence or anyone that came through with a positive urine toxicology. We excluded pregnancy, and then, of course, anyone that was unable to provide informed consent and assent in the case of the adolescent. I will say a note about controls and blinding here. So folks that are familiar with the pediatric depression literature know that placebo rates are really high in depression trials, and they're super high at times in pediatric trials. And so we thought having a placebo and having a robust placebo was really important. So we chose midazolam as an active control. We also put in place additional measures to protect the blind, including having separate efficacy and safety raters. So that means if you were present for the infusion doing the safety ratings, a separate person was performing the efficacy ratings who had no access to what was going on in the infusion. So the Child Study Center lit up at night, looking beautiful, is where we did our efficacy ratings. And then the hospital research unit at Yale New Haven Hospital is where the infusions took place. In terms of the study design, this was a randomized midazolam-controlled crossover trial. So a crossover trial meaning that you get both compounds in a randomized sequence separated by a certain amount of time. So this was a 4-week trial. Infusion days were on day 0 and 14. So sort of a zoom in on the infusion day. So the infusion of either ketamine at this 0.5 milligrams per kilogram over 40-minute dose, or midazolam at 0.045 milligrams per kilogram over 40 minutes, which was followed by conducting side effect rating scales. So we used the CADS, which looks at dissociative symptoms at 1, 2, and 3 hours. And then we did some PK studies, so collecting serum to look at ketamine metabolites. As you might imagine, we talked with these participants often. So we did rating scales at the dates that are shown here. And then in a small subset of participants, we also did some functional neuroimaging at the 24-hour time point. So we assessed 26 people for eligibility, 19 consented for the trial. Of those 19, 17 went on to receive the first infusion. So 1 withdrew due to an undisclosed medical condition, and 1 panicked right before we started the infusion for the first treatment and withdrew. Of those that received the first infusion, the investigational drug service ran 11 to receive the sequence of midazolam and then ketamine, and then 6 to receive the sequence of ketamine and then midazolam. Of the folks on the left, 11 went on to receive the second infusion. And then on the right, we had 1 participant that withdrew after the first infusion to go receive ketamine in the community. And at unblinding, we realized that person did indeed receive active ketamine for infusion 1. This is telling you about our subjects. So our sample was predominantly female, which is consistent with the increased gender difference you see following puberty. Our average age was 15 and a half, but this histogram here shows that I think we had pretty good representation across the age range that we were targeting. The baseline CDRS was an average of 63, which is high and pretty similar to the sample in the Tordia trial. The age of depression onset was 13 years, and the duration of current episode was 21 months, even though there was some variability there, but really a chronic sample. And then the average number of failed antidepressant trials was around 3. So you'll remember that the requirement was to have failed 1, but most of our folks had tried lots of things. This is showing the history of suicide attempt in about half the sample, 60% also having a history of non-suicidal self-injury. And then if you'll recall, this was a study where we had folks stay on their medications, presumably an ineffective medication regimen, but this is showing the breakdown of the types of medicines that people were on. So a large percentage on either an SSRI or SNRI, a little over a quarter getting antipsychotic augmentation, 1 person on lithium, 2 folks on a mood stabilizer, and 2 that were not taking any medications. So the primary outcome for the trial was the day 1 MADRS score. And so this is sort of the main figure from the paper showing that ketamine decreases depression scores at 1 day following infusion in adolescents with TRD. This was an effect size of around 0.75, which is pretty similar to the adult literature for midazolam-controlled trials. If you're looking just at saline-controlled trials in adults, the effect size is a little bit higher. This figure is showing the percentage of responders. So we're using sort of the classic criteria of a response being a greater than 50% decrease from a baseline depression score within the 3 days following treatment. So you can see here that we had 5 folks that had a response to both ketamine and midazolam, 1 person that had a response to midazolam only, and then 8 that had a response to ketamine alone. And you can see that just represented a different way here. I think we've bolded the most salient comparison, which is 8 people having a response only to ketamine and 1 person having a response only to midazolam. And then this is looking at the time course. So this is showing that in these 16 subjects, the depression scores remained improved at the group level for up to 14 days, which was the longest time point that we looked at in this short-term study. This is some unpublished data. I figured since I put that we were talking about suicidality in the title, we should talk about what data we have in this sample. If you remember, the level of explicit suicidality was relatively low as it's an outpatient study, but a subset of folks did an implicit association task. So if you're familiar with these, it's a task where it measures your reaction time to assess how quickly you sort various words that come on the screen. And the idea is that you're better at sorting words that you already sort of implicitly associate with yourself. So if you're depressed, you may associate sad with me more quickly than you would associate happy with me. And so the sorting speed reflects how tightly you associate any 2 concepts together. And so if you are faster, that indicates a stronger association. So this is some preliminary data from that group. So we did 4 different IATs, 1 focused on depression, 1 focused with suicide words, 1 focused on self-harm words, and 1 with anxiety-related words. And you can see that we have some nice separation that just escapes significance here in the subset of people for depression and suicide, and really less of a signal for things like self-harm and anxiety. So even though the level of suicidal ideation explicitly in the sample was low, I think this is sort of an interesting, promising signal at the implicit level. I'll talk about how folks tolerated this and side effects. So like I said, we use the CADS to measure dissociative symptoms. I think, the alternate title to the slide is that midazolam is not a perfect control for ketamine, right? So you can see that there's a significant difference between the 2 treatments in terms of side effects here at this 1-hour time point. But I think the other important point is that these are really self-limited effects that resolve by the 2-hour time point. I find this kind of interesting. This is what we pulled out as the most common intra-infusion side effects. So these are individual items from the CADS. And so I've highlighted the ones that are similar across ketamine and midazolam. So large percentages endorsing feeling like they've spaced out. Also some reports of feeling disconnected from their body, although that's more heavily in the ketamine group. And then some that really seem distinctly ketamine. So a lot of people report this feeling like they're in a dream, and we really don't see that with midazolam. So the blinding of ketamine continues to be a challenge. This is looking at safety from the hemodynamic standpoint. So this is looking at blood pressure, and you can see that ketamine increases blood pressure relative to midazolam. We had 4 participants that had blood pressures that met the criteria for adolescent stage 2 hypertension, which is 140/90. But none of those persisted past the end of the infusion, and nobody exceeded 150/95. So tolerated this pretty well. So the single dose conclusions I have from this small study was that in this sample, ketamine was well tolerated. It significantly improved depressive symptoms at 1 day post-infusion as measured via MADRS in adolescents with TRD. And while we don't have any information here about explicit suicidal thinking, since there was an exclusion for this study, I think there's some interesting sort of preliminary data using the IAT. So I think this preliminary data suggests that ketamine may be safe and effective in the short term, but as we followed some of these folks informally after the study, people relapse after getting a single dose. The effects are really ephemeral. And so I think the real conclusion of this study is that we need more research because the gaps in our knowledge are considerable. And so for this last part of the talk, I'm going to identify some of the gaps that I think are the most significant, and I'm interested to hear what folks have to say. There are many gaps, and so we can talk about what we should prioritize. But the first one that I think about is how to extend ketamine's antidepressant efficacy and this idea of repeat dosing. So this is a paper from Singh et al. In 2016 that was looking at repeat dosing and sort of an acute series. And they showed that twice weekly dosing over 3 weeks yielded remission that lasted for an average of 3 weeks. But there was a considerable range of durability there. So some people were better for greater than 3 months. Some people were only better for 6 days. And it's really not clear what the individual factors are that predict who's going to have a sustained response after getting a series or not. We have a little bit of experience with repeat dosing at the case report level. We published this back in 2017. This was a 16-year-old boy that had a history of ADHD, depression, and Crohn's disease. He had 3 prior serious suicide attempts. He had failed multiple pharmacologic treatments and psychotherapies across a range of different levels of care. And we were considering ECT, but opted for a ketamine trial at that time. So this is an adaptation of the figure from that paper, looking at the MADRS as a measure of depression and the SSI as a measure of suicidal ideation. These arrows are showing the individual ketamine infusions, and you can see this nice decrease in both depression and suicidality rating scales, and one that improves with subsequent infusions. I think people always say, what happened at day 30? And what is this sort of blip on the radar here? And this was a day where the team and the patient found out that his insurance was denying the discharge plan. We had found a really great sounding residential, and insurance decided that that was not the right thing to do. And so I think everybody's frustration was increased at that time. But I think that's an important lesson, right? Is that even if ketamine is improving these symptoms, I don't think it immunizes you from feeling disappointed when disappointing things happen. But overall, his scores recovered, and he did pretty well during the period that we followed him. So what's the deal about repeated dosing? Why wouldn't we just, start doing repeated dosing for everybody? And some of the things that give us pause come from studies of people with ketamine use disorder or who have used heavy amounts of ketamine recreationally. And although there's, potential confounds looking at that population, there are concerns about ketamine causing neurocognitive declines or neurocognitive damage. And then also a focus on potential bladder damage or cystitis. So one of ketamine's metabolites can be very irritating to the bladder and can cause this chronic problem. And then the other set of data that gives us pause about repeat dosing are animal studies. So animal studies using chronic dosing in young animals showing damage to developing hippocampus and prefrontal cortex. So serious things like cell death and white matter changes. And the issue is that the toxicity threshold of repeat ketamine exposure is really not known. We know that there's an amount that is safe. Ketamine, as I've said, is used frequently in medicine without a lot of problems. And then we know that there's an amount out there that's probably too much from these animal studies and abuse studies. But where that threshold lies and where it lies at each developmental time point is really an open question. And then I think a second gap that I think about that also relates to the idea of repeat dosing is what do you do after an acute series of ketamine or S-ketamine? And so I'll talk first about adults because there's actually pretty good data out of the S-ketamine data sets about the idea of using maintenance treatments. So a lot of the initial ketamine paradigms were sort of modeled on ECT, where you cluster some treatments at the beginning and then you sort of space out and have some sort of maintenance approach. And so this is from a study that came out in, or at least was published in 2019. So this is with the S-ketamine program. And this was looking at adults who had achieved a response or remission with acute S-ketamine treatment. So S-ketamine generally does 8 treatments over 4 weeks. And then they randomized folks to receive S-ketamine maintenance, which was either once a week or once every 2 weeks with S-ketamine, or a placebo maintenance. And so here you can see they have a survival curve in terms of remission. And you can see that the folks on S-ketamine maintenance do better. And then this is looking at a separate population. So instead of using remission as the criteria, using response as the criteria. And then there are ongoing studies in terms of the safety question, because there's sort of the efficacy question and the safety question. And in terms of safety, there's still some ongoing data collection that Janssen's doing during the post-market phase. So following folks that have been on S-ketamine maintenance for quite some time, either at every week, every 2 weeks, and it seems like they also have a group that are doing monthly treatments. And some of those folks have been followed for over 3 years. So it'll be interesting to keep following those data sets. So that's probably the best data we have in adults. And then with pediatrics, we have basically like no data, very little data. And so what do you do after an acute treatment series? Option 1, do we do something like a maintenance procedure? And if so, how many, at what intervals? But what I'm really interested in is this idea of whether we can harness the period of wellness in ketamine responders by really amping up our use of more traditional psychiatric treatment approaches, that people are in a better place to engage with things like psychotherapy. And I put up another busy cartoon, but just to remind you that all the busy cartoons are trying to say that ketamine enhances synaptic plasticity. And so a question is whether this period of ketamine-induced enhanced synaptic plasticity, could that allow for psychotherapy to be more impactful? So my colleague, Dr. Wilkinson, is starting a study just now that's looking at CBT augmentation in adults with S-ketamine. But I have reservations about giving ketamine, particularly in pediatric patients over the long haul, if there is a way to do a different treatment approach. And so I'm very interested in studies that would look at this question. A third question that keeps me up at night is, do the antidepressant effects hold in larger pediatric samples? I like this this cartoon that says, the tortoise and the hare is actually a fable about small sample sizes. And he says, after 19 additional trials, of course, the results were shown to be anomalous. And, sadly, that is a history in our field of getting really excited, looking at small sample size studies and then things not panning out in larger samples. So we really need more studies that are designed well and done ethically, and we really need that data now. And then I think the other question for pediatrics is, what about suicidality, right? This idea about ketamine being distinctly anti-suicidal. I think we need to do more studies that are specifically looking at suicidal populations. And then the last question that I think about a lot is ketamine for whom, right? So which disorders are sort of the best fit for ketamine? And of course, we've talked predominantly here about MDD, but there's also some data, mostly in adults, that suggests some efficacy in OCD or suggests some efficacy in anxiety or PTSD, and maybe others. And I think, when I first started thinking about this, I felt uneasy about it because I thought, is ketamine a panacea? It works for everything. What does that mean, that there's little specificity? But then I think back to where we are with SSRIs, right, which are first-line treatments for the disorders that are listed on the screen. So it would not be the first time that a medication could be used across multiple psychiatric indications, which maybe says something about our diagnostic categories, but I'll save that for another day. So another question about ketamine for whom is, are there certain clinical features or predisposing factors that that would make someone a better candidate for ketamine treatment? And there are some studies indicating that maybe anxious depression or folks that have a significant amount of anhedonia might be better candidates. There was some data that came out recently suggesting that folks that had a history of early childhood trauma had better ketamine responses. So I think those are all really important questions to think about. And then finally, what about biological features or biomarkers? We have this goal of getting to a place of personalized medicine and trying to avoid, what is effectively our strategy right now, which is just we try things empirically. We try something, if it doesn't work, we try something different, and we keep, moving through these things without a lot of guidance from the science about which thing to try or which patient might respond to which medication. So to summarize the gaps, these are the ones that stand out in my mind. So how to extend ketamine's antidepressant efficacy, especially when the risks of repeated dosing are not fully known. How to optimally extend efficacy after an acute series. And I'm particularly interested in harnessing more traditional psychiatric approaches. Does ketamine really have antidepressant properties or anti-suicidal effects in pediatric populations? We really need more data about that. And then personalized medicine approaches. So who are the best candidates? And can we predict the treatment responses ahead of time? And so in the last 5 minutes or so, I'm going to talk about a couple ways that my lab is thinking about asking those questions or getting at some of those questions. And I'm going to talk about 2 repeat dosing trials that we are working on. So the first one we call the SAD Kids trial. So the Severe Adolescent Depression Ketamine Intermediate Duration Study. We worked very hard on that acronym. And this is a foundation-funded study from ACAP and the Klingenstein Foundation. And then we just got a big grant from NIMH to conduct a study we're calling the READ study, so Reducing Adolescent Suicidality, Safety, Efficacy, and Connectome Phenotypes of IV Ketamine. And I'm talking about these two together because they share sort of a similar design. And so these are 2-phase clinical trials. And in the first phase, we enroll and randomize people and give them a repeat ketamine paradigm. And so in the SAD Kids trial, it's 6 infusions over 3 weeks. And then we sort of condense that in the READS trial to 4 infusions over 2 weeks. But a short acute treatment phase. And then folks move on to an open phase. We actually break the blind, see what people got. If folks were randomized to ketamine, they go straight through to the open phase, where they're given standard depression treatments, weekly mood assessments, and monthly cognitive and mood batteries. And this is a feature that I like about these designs. I feel like they're participant friendly in that if folks are randomized initially to midazolam and they don't have a response, they're given the option to cross over to open ketamine, which I think balances the rigor of a parallel design trial, which is important to do, but balances that with the obligation to offer active treatment to suffering teenagers and to get more safety data on ketamine use in pediatric populations. The populations for these 2 trials are slightly different. So in the SAD Kids trial, we're looking at pediatric TRD, so having failed at least 2 prior antidepressant treatments, and the primary outcome is a depression outcome. And then in the READ study, we're enriching our population for suicide risk. So they have to both meet criteria for pediatric TRD, but then have had a recent suicide event within the 4 months prior to enrollment. That's either a bona fide suicide attempt or a degree of suicidal thinking that required an escalation of care. And the outcome for that study is a suicide outcome. So we're using the ideation subscale of the Columbia. So 2 studies going on here. And then the last part, you might notice this brain just appeared underneath enroll and randomized. And I'm going to talk a little bit about how we're trying to incorporate some predictive neuroimaging into these clinical trial designs. So this is a collaboration with my colleague, Todd Constable, in the radiology department, trying to use functional connectome response predictors to see who might respond to ketamine. So Todd's lab developed this very cool technique called Connectome-Based predictive modeling. And what they do is they use a combination of task-based and resting state fMRI, and they use it to try to tweak or stress the brain across different neurocognitive domains. So he always uses the analogy of, if you do an X-ray of someone's heart, it might look normal, but you want to do a stress test. You want to see how it actually functions when you're asking it to do something. And so a similar way of thinking about the brain is you might look at a resting state kind of data set and things look fine, but you really want to stress the brain across different domains. And so he's designed this battery that tries to get at several different RDoC domains. And by doing this, they're able to generate these highly individual connectome fingerprints, which you can then associate with a clinical dimension of interest. We've been able to get the scan time to less than an hour, so I think that's patient-friendly to do. And what's cool about this is, he's published work showing that it's pretty good at predicting psychiatric symptoms. So they're able to predict inattention scores in an ADHD sample. They're able to predict autism symptoms in a mixed sample of ADHD and autism patients. And then some folks have started to apply this to treatment outcomes in the adult population. So my colleague Sarah Yip published a paper in AJP a few years ago using this procedure to predict treatment outcomes in adults with cocaine use disorder who were undergoing substance use treatment. And so I think this is a really cool way to try to start looking at whether we can use brain-based measures to predict responses in clinical trials. And then I have this last slide, which is just highlighting, so the grant, I put my grant at the top, which is the READ study. But I'm really encouraged that NIMH has decided that this is a worthwhile place to invest. And so there's several pediatric IPS studies that are about to start in the US. So one at Cleveland Clinic and one at UT Southwestern. And then I've added at the bottom, my colleague at Mayo is starting an RTMS study for pediatric suicidal ideation. So, I sort of got on my soapbox at the beginning saying that we've had no major updates since Tortia over 10 years ago. And so I'm encouraged that some of our funding agencies seem to appreciate the urgency that our clinical colleagues feel in their office every day with pediatric patients with severe mental illness. So my last slide, my conclusion, at least the current status as I view it for pediatric patients, is cautious optimism in terms of using ketamine for serious mental illness. I think the unknown risk profile of repeated exposure really complicates how to do an appropriate risk-benefit analysis. And so when I'm thinking about patients that might be appropriate, if there's not a clinical trial that would be suitable, I think we want people to be truly treatment resistant and to carefully confirm past treatment trials. So having a good shot at both medication and psychotherapy, being very clear in the informed consent process about risks, benefits, and just the overall state of understanding in the field. And then always having direct supervision by physicians with adequate training, and then really having a robust follow-up plan and collaborating with the primary psychiatrist if you are not the primary psychiatrist. So I will stop there. This is just a thank you slide. It shows the funding for the work that I've shown. Michael Block was my mentor and postdoc, and he's my co-director for the Pediatric Treatment-Resistant Depression Program. He's a wonderful person to work with. Jerry Sanacora, who's also a mentor and colleague who's helping me with the R01 study, Kevin Kaloris, who was a pediatric anesthesiologist at Yale, now at Stanford, that helped us design the initial study, and then my medical student, Natalie, who just left to go start in psychiatric residency in San Diego, but had been really integral to our work over the last year. So I really appreciate your attention, and I'm going to stop sharing my screen, and I'm excited about the discussion that we can have.
Hi, Jennifer. Thank you so much for this wonderful presentation. I'm sure all your residents and all your audience are really happy to listen to you. That was a terrific presentation. I'm so glad to hear you.
Thank you.
Well, so Professor Acioly, you can give your comments, please.
So firstly, thanks a lot for inviting me for this event, this very high quality event. And also I congratulate Professor Dwyer for the terrific presentation. I have the opportunity to see a previous presentation from her, and really insightful presentation. Basically, Professor Dwyer, she took us the main questions, the main challenges we have now regarding the use of ketamine or sketamine for treatment of mental disorders, severe mental disorders. We have basically different situations where we should take decisions that are really cautious, and we still need to measure in detail the pros and cons of using ketamine or esketamine in different psychiatric disorders. Now we have mounting data of the efficacy and safety of ketamine, especially esketamine, with the phase 3 studies from Janssen, demonstrating the efficacy and also safety of long-term and repeated dose of esketamine for treating treatment-resistant depression. We have, just to cite one study, the SUSTAIN 3 is running for about 5 years. And those patients have been treated in a frequency of weekly or every other week or monthly for 4 or 5 years, and you have no serious adverse event directly related to esketamine in this population. This is a population. This is an adult population from 18 to 64 years. So the main problem now is regarded to some aspects of the use of ketamine or esketamine. First one is related to the extremes of the lifespan. So we have a limit amount of data in both adolescent and children, and also in elderly people. So the studies, the phase 3 study of Janssen, specifically examining the elderly population, this was a transform study, so a short-term study, and they found a negative. They had a negative study. In our practice, we have a lot of real-world data in our ketamine clinics, and in fact, we have confirmed that in the elder people, we have the treatment is not so effective in a short term as compared to younger populations. But when you do a long series of repeat dose, we get basically the same results as compared to younger people. So probably for the elder people, we have a more the antidepressant effect is not so early as it happens in the younger population. So we have got very good results in a real world setting with elderly people, but the result is not so early as it happens with younger people. But we don't obviously we don't have a systematic comparison of those populations. So basically our data from real world settings, we have hundreds of patients at those range of age, so people over 60-year-olds, and so probably this is a difference that is lacking studies with appropriate design to check if this is a real difference in efficacy in this population, or basically is a population that has not an early response as it occurs in younger people. In the phase 3 studies, we also have some sub-analysis that showed us some insightful results. So specifically in the elderly population, the subgroups that do not respond or do not separate from placebo were two subgroups. One subgroup of patients where the first depressive episode occurred after 55 years old. So probably in this population, in this geriatric depression population, we have more vascular events. And this is probably a marker that's related to a poor response to esketamine or ketamine. And also in the second subgroup that did not respond, did not differentiate for as compared to placebo group, was patients independent of the age at onset of the disease. They were above 75 years old. So again, probably we have more vascular events, cerebral vascular events, and also the reason probably is the same and is regarded to a poor response. That's not a poor response that is restricted to ketamine or sketamine. All intervention, all biological interventions, they have a decreased efficacy in this population where cerebrovascular events are more common, are more prevalent. So regarding the other extreme of the lifespan, the children and the adolescents, as Professor Dwyer has showed us, probably the response is quite similar to the response observed in adults. So the effect size she reported, the effect size we have seen in literature, even considering a very few number of studies, especially with when we talk about controlled studies, the effect size appear to be very similar. And even the single dose studies, as the study presented by Professor Dwyer, the response rate is quite impressive as compared to adult population. And probably in this population, the main problem is regarded to the limit number of controlled studies. But probably when we have these sufficient numbers of controlled studies, the results will be quite similar to adult population. There is still one question. Is the question regarded to safety of the repeated and long-term use or exposure to ketamine or sketamine to this population where the brain development is still ongoing. We have a neurodevelopmental stage that is quite vulnerable to effects from environment. So I think this will be the main question to be carefully examined in the younger population. We have still different gaps regarding the use of ketamine and sketamine in psychiatric disorders, as pointed by Professor Dwyer. So we don't know how to do after finishing the series of ketamine and sketamine. So what's the best treatment after that? We don't have this response so far. At least we have the SUSTAIN 3 has showed us that the long-term use of repeated dose of sketamine is apparently safe. And also another important finding for the SUSTAIN 3 is that the antidepressant effects of sketamine, they don't develop tolerance after several months or even years. The efficacy is basically the same. So we have also not seen any negative impact on on cognitive performance of those patients. So it's also a very good news for these issues. Basically, this is our main comments. And now I would like to listen for the Victor comments. Thanks again for the invitation, and congratulations to Professor Dwyer for the terrific job.
Thank you, Professor Acioly. Thank you so much for your comments. So, Victor, please, you can give your comments now. Oh, your audio is muted. Sorry. First of all, thanks to Professor Dwyer for this lecture. It's a pleasure to be here with you and with Professor Lacerda. The work of Professor Dwyer is a pioneer in the study of ketamine in teenagers. And I'm looking forward to see the next results of the next studies that she will conduct. Most ketamine studies, as we know, and as said by Dr. Dwyer, are with adult patients ranging from 18 to 65 years old. Basically, regarding to depression and major depressive disorder, has a high prevalence throughout life. In São Paulo, this prevalence is estimated in 18%. Another problem is that data from the STAR-D study, as said also by Dr. Dwyer, showed that about 30% of patients with major depressive disorder do not respond to 4 or more attempts to treatment with antidepressants. In teenagers, also as said by Professor Dwyer, the number is still high. About 20% of teenagers with major depressive disorder do not respond to at least 2 treatment attempts. The main mechanism of action of major antidepressants, as we know, is acting on monoaminergic system, serotonin, noradrenaline, and dopamine. And ketamine, over the last 20 years, has shown another possible mechanism of action in treating depression by involving glutamatergic pathways, more specifically through an antagonism of NMDA receptors. And in the last few years, studies involving ketamine, as an enantiomer of ketamine, have grew due to its more potent NMDA receptor antagonism. After several studies with intranasal esketamine, this led to the approval of intranasal esketamine in 2019 by the FDA and other agencies around the world. Here in Brazil, Anvisa approved the intranasal esketamine for the treatment of treatment-resistant depression in the end of 2020. But it is still not available for the use because of a pricing process. Data from many studies shows a response of 60 to 7% to racemic ketamine and esketamine in treatment-resistant depression. Most studies employ the intravenous route in an infusion for 40 minutes, and lately, intranasal route was the target of many studies. And more recently, esketamine in subcutaneous route, especially here in Brazil, in studies conducted by Professor Lacerda, showed similar rates of response than intravenous and intranasal routes. And some of the advantages of subcutaneous route are the cost, it's cheaper, and maybe with a better tolerability. Also, data from a pilot study with 7 patients conducted by Professor Lacerda showed encouraging results with the use of intravenous ketamine, which is the other enantiomer of ketamine.
5 patients responded in 24 hours, and 4 from the 7 remitted in 24 hours, with almost no dissociative effects and good tolerability. Knowing all these encouraging results regarding ketamine and its enantiomers in the short term, with good tolerability and usually with transitory side effects, we will still need data of safety and efficacy in the long-term perspective with long-term assessments. And I think it is also valid for the pediatric population. In our group here in Hospital das Clínicas, we are monitoring a sample of 10 patients receiving intranasal ketamine. We are trying to include more 5. It's a small number, but the idea is to follow them systematically with neuropsychological tests, efficacy and safety assessments during their lives. We are still in the first months of observation. There is still a long run. What we have seen is that when we try to space the sessions from weekly to every 2 weeks in the maintenance phase, patients tend to get worse, and we have to put them again in the weekly frequency. We see this tendency to maintain weekly sessions to sustain their response. But this is still an initial impression and a small sample, and a sample receiving intranasal ketamine. With regard to suicide, 10 to 20% of patients with depression will attempt suicide over their lives. So suicidal ideation may be a frequent symptom in depression. Suicidal ideation is associated with a worse prognosis, greater severity of depression, and worse response to every treatment. In 2018, data from a study with racemic ketamine that enrolled 80 patients with frank suicidal ideation in the emergency department of Columbia University showed a more intense reduction in suicidal ideation than in depressive symptoms. This led to a discussion that the anti-suicidal effect could be independent than the antidepressant effect. Some possible mechanism of action of ketamine and suicidal effect have been proposed since that. For example, the anti-inflammatory effect, the improvement in anhedonia, the effect on the full mode network, improvement in brain disconnectivity, and even the improvement in pain. In the other way, a more recent study, the Aspire 2, with an even larger sample with more than 200 patients with intranasal ketamine, showed a significant reduction in depressive symptoms compared to placebo, but not significant for suicidal ideation specifically. So one question that raised is, could be the anti-suicidal effect a pseudo-specific effect of ketamine and esketamine, or esketamine has less impact in suicidal ideation than racemic ketamine, as the study conducted in 2018. In an open study also by the group of Professor Lacerda with 59 patients, no difference were observed regarding suicidal ideation between intravenous esketamine and intravenous racemic ketamine over 7 days of observation. But I think it is still a question that remains open, because it was a pilot study, an open study, and I think the question remains open. The impression of our group is that the improvement in the thoughts of death and suicidal ideation in major depressive disorder usually follows the overall improvement of depressive symptoms. Also, the worsening of depressive symptoms tends to lead to a worsening in thoughts of death and suicidal ideation during ketamine treatment. Again, it's a small sample. They are not in the emergency department. They are outpatients, and they are taking intranasal ketamine. I think this is my considerations. Again, it's a pleasure to be here with Professor Dwyer and Professor Lacerda, and thank you again for the invitation.
Victor, thank you so much for your comments. Really appreciate to have soon in our greenhouse your findings, your preliminary findings here that you could present for us. Professor Orestes, Euripides, please feel free to give your comments.
I think we don't have much time, but I think I'm eager to hear Jenny's comments on the comments from Acioly and Victor, and maybe Rodolfo, if you have some questions from the panel, it'd be great.
Yeah, I mean, I was going to say, I think the geriatric finding or lack of finding is very interesting, and I think about, as ketamine, this idea of enhancing synaptic plasticity being a really key mechanistic component, and whether there's something about the aging brain where there's sort of less plasticity potential, and that maybe, I think it's interesting that you found that people did eventually respond, but it took more treatments. And I wonder if it's kind of a system that just needs some repeated prodding versus, a young adult or an adolescent. So that was a thought that came to mind about that. And then Victor's comments about the question about anti-suicidality. I think so many of those issues, I was wrestling this as I was putting together my suicidality study. So much of this relates to when are you measuring people and sort of the natural course of illness. I think I admire that Janssen was, going for these really, imminent suicidality, tough patients. But I think the downside statistically is that when we admit people to the hospital, many have rapid remission in the suicidal thinking and get discharged, ketamine, esketamine, or no treatment. And so I think in some ways the signal detection may have been, compromised is maybe too strong a word, but signal detection is a challenge when everybody is likely to improve to some degree. And I think our scales aren't fantastic for suicidal ideation, so it's kind of hard to detect a change on those scales anyway. But it's such a critical question. And as I said in my talk, I think particularly living in the era of the black box warning, where antidepressant and anti-suicidal effects, don't have to go together. I think it's a really important question. So thank you guys for your thoughtful commentary.
Thank you very much, Dr. Dwyer, for excellent talk. I quite like the way you pose this matter in a very bold and pushing toward the limit, but also very conservative and cautious about the need to have data and fill the gaps. Many things you don't know, and must be very careful about that. It's a very important message to deliver, while we are also excited with the promising results. My question, of course, would be something related to geriatric psychiatry, my field of expertise, and you have already addressed it. There is still any room for deciding whether late onset or early onset depression could respond differently. As you said, the results are not very exciting in older patients, but perhaps in these two different subgroups of depression, there could be some possibilities.
Yeah, I mean, I think, depression is likely the depressions, right? And how many subgroups are there? I'm sure there are some, and trying to figure out what is the, best way to shake people out in a way that is useful in thinking about treatment. But for geriatrics, I do think about sort of the stress diathesis model of depression neurobiology, and the idea that, chronic stresses, repeated depressive episodes over time are really damaging to, the synaptic plasticity potential in these areas. And and as we've been thinking about sort of the pediatric dosing kind of thing, I have this, hopeful hypothesis that maybe, pediatric patients could do well with a shorter course, that there's such plastic potential at younger ages that maybe you could get away with a shorter treatment course and then really amping up the psychotherapy, psychosocial supports. Many of these kids have just been, not living their lives to the full potential during these depressive periods, and trying to kind of, sort of like a psychoanalytic idea, right? Like Anna Freud's developmental lines, trying to get them back on track. There will, I think, just like ECT, there are some patients that probably need ECT their whole lives. There are going to be patients that probably need something like ketamine in an ongoing way. But I hope that there's a way to figure out paradigms where it's not the majority.
Thank you. Rodolfo, any pressing questions from the audience, please?
Yes. There is a question from Rafael Neves, our resident, our first year resident, a really good resident. So he asked if there is any difference regarding the effect of ketamine in specific depression subgroups. For example, borderline personality disorders, because we also know that this is a very comorbid issue in adolescence and during childhood. And if you are also controlling for it in your studies, or if there is someone looking for it, because I saw in clinicaltrials.com that there is a clinical trial with ketamine infusions in borderline personality disorders being conducted at Yale University too. Yes. And we also know that there is a high expression of glutamate in insula of these patients, and maybe it could be something really important for reducing suicidality or depressive symptoms in this population. So if you could please explain a little bit more for us.
Sure. Residents always ask the hardest, best questions. So my colleague, Dr. Feinberg, is doing the borderline personality disorder study. I'm actually seeing her later today, so I will let her know that people are talking about her study. I think in practice, particularly in adolescence, it can be really difficult to try to tease out MDD versus borderline personality disorder. I think some of the features or interaction styles that sort of characterize classic BPD can be almost developmentally normal depending on the situation in adolescence. So, idealizing and devaluing, caring very much about rejection from peers. I mean, we expect that. And so I find it there are certainly cases where you say, I would call this borderline personality disorder, but I think many times, I don't think our diagnostic categories are that good. And so we do, look at BPD features, and we want people to really meet criteria for a major depressive disorder and episode, so sort of sustained symptoms over time. But I think it's a really tricky issue. And, maybe a nicer way to say it is we're interested in, anti-suicide effects transdiagnostically, like suicide is not associated with depression, and BPD has, a really high risk for things like that, as do other, psychiatric disorders. So I think I'm glad that my colleague is studying it. And I think even though a lot of the other ketamine studies have really tried to sort of separate it out, I think in practice, it's really difficult to separate those cases out in a clean way. So I think ketamine probably has been studied in some patients with borderline personality disorder without having called it that. But great question.
Great. But in your practice, do you see that reduced efficacy of ketamine in the subgroup of patients or no?
I mean, our numbers are too small to really do meaningful subtyping at this point. You know, our bigger study, we're looking for 66 folks over like 3.5 years. And so I hope as we start, you know, getting our numbers bigger that we'll be able to do more of that work. But I just don't feel confident subtyping ends that small.
Great. Professor Euripides Orestes, if you have any questions, further questions.
So thanks a lot, Jenny, for being here. Appreciate a lot. Wonderful talk. Thanks, Acioly and Vitor, for complementing her talk so well. I have one question, Jenny. As you raise the gaps and the future in terms of new studies, how do you see the tendency or for the answer for the what to do after the acute treatment? Do you think the tendency will be to replicate findings from like the daily paper in the JAMA, suggesting that we should keep patients in ketamine, for instance, or do you see any new, any previous or current class of antidepressant being an option to keep this patient in a long term?
Yeah, I mean, I guess I put my money more on psychotherapy than any specific medication. And I'm excited that there are more studies that are specifically looking at things like CBT or even some of the other evidence-based therapies, you know, interpersonal therapy for adolescents, those sorts of things. You know, our approach has really been to load up standard of care treatments after the acute phase. We actually had a limited number of maintenance infusions allowed in one of our protocols, but the FDA is very conservative about pediatric ketamine. So they limited us to 8 total lifetime infusions. So we kind of couldn't study it even if we wanted to right now. But I'm glad that there's more than one group. There's more groups other than mine working on this because there is so much work to be done. And so, you know, the more people that are interested and are doing it in a careful way, the better. We really need it.
Thank you.
Thank you so much for inviting me. If anyone has other questions or wants to say hi, you can always email me. But I really appreciated getting to know your departments and visiting with you.
Thank you. Hope to have you here.
Thanks so much.
Yes. Okay.
And also,
Thanks a lot.
Bye-bye.
Thank you.
Bye-bye. Thank you so much.